Good afternoon to everybody. Welcome to Joe's Sunday Funday. So for those of you who are not familiar, you're in the absolute left ventricle of my life. Yes, you are. This is my garage, guys. So let me give you a little tour for those who haven't seen it. So here we're going out, right? Here's the workout stuff. There's the couch. There's my kegerator. There's my big widescreen TV, guys. And so believe it or not, when I'm doing all these handouts and things for the school, believe it or not, you are literally in the nucleus of my office right here, guys, in my man cave. So there you guys go. So welcome to my man cave. You're here. All right. So let's go do this, guys. Okay. So let's go do the subject that you hate, which is the anticoagulation. And I know in school, you guys go over certain things and then you get out in the real world and it's like, do I use aspirin? Do I use heparin? Do I use Xarelto? You know, it's like, you know, some people Coumadin, and you're walking around and you're going, you almost feel like you're guessing half the time, right? You're like, Xarelto is the right answer. Or it's like, maybe aspirin and maybe this. And you'll see there's a method to the madness here, guys. There's actually some logic to a lot of this. And I think in school, what happens is you kind of go over that cascade thing that you probably brutally memorize, you know, the XA, the 10 factor, the 10A factor, or the thrombin to the prothrombin, or this to that. And by next thing you know, you're like, you still don't know when you should use Coumadin. And then you get out in the rotation, you're like, why is he on Plavix and aspirin? Why both? You know, and so this kind of confusion goes on. And I see this all the time in the real world, guys, when I get out there. So yours truly, I've been working the ER. Next month will be 38 years. So it's just that you see this. So let's kind of break this down first. Okay. So what I'm going to do here, guys, is I'm going to share my screen with you here. Okay. So I'm going to share my screen. And so let's just kind of go over what you learned in school, right? Which is this, right? So what you learned in school. So you were sitting there in school and you were saying to yourself, okay, so this is what I learned, Joe. I learned about, you know, these factor XA. I learned about this. I remember something about the prothrombin, going to the thrombin, and then the fibrinogen, going to the fibrin. So what I need inside of you now is this. I need you to pull back and get away from the memorization. What I want you to look at is say, you know, Joe, there's a lot of places I can jump in and really stop this clot from getting bigger. There's a lot of places in this cascade where you make a clot where I can jump in. That's the take home message here. This isn't about memorization. What this is about is that, hey, you know, I can come in here and block it here. I could block it here. I could block it here. I could block it here. So I want you to view these as roadblocks. So what you're really looking at is like, where do you want to put up the roadblock? Well, I could put it in between when factor XA becomes thrombin. Yeah, I could do it right here. This is what we call our XA band. So we'll get to this in a second. And see the XA? Well, that's 10A. Well, that's 10A. Get it? It's in the word, guys. It's in the word. It's telling you it's at the 10th A level. That's your XA bands. And so this is what we're seeing here, right? Okay, so this is what we're seeing, all this, right? Okay, so what I'm really needing inside of you now is, I see what you're saying, Joe. So you're telling me that Coumadin comes over here and blocks it here. Exactly. And then dabigatran or Pradaxa blocks it here. Exactly. And this is where I want you to really start conceptualizing this, is that I'm really talking about where I block it. That's what I need inside your head. It's no longer this. It's more like, where am I blocking this? And this is the point I'm really trying to make to you, is that, right? It's like, where do I block it? And that's the point I'm trying to make to you, is this, okay? And then, of course, what did you see? We're going to get this in a second. So what have you been seeing a lot of? Oh, my gosh. That's all you see now is Xarelto and Eliquis, isn't it? And you really have to stop and think about this for a second. Why are we seeing so much of this? So you get out in the real world, like, you know, come to work with me tonight. I mean, I promise you, we'll probably see some DVT before the night is over, right? We'll see some DVT. And what I like to say to you is this, is that what's really going on here is that, you see, you can basically use it with almost about anybody. In other words, you don't have to eat the green leafy vegetables, right? Remember the vitamin K? Remember that in school you learned about Coumadin? You're like, oh my gosh, you know, vitamin K rich foods, you know, in other words, I can't eat them when I'm on Coumadin, right? Okay, so this is what I need to, Hey guys, I need you guys to mute yourself. Hello, good morning. Hi, who's one that's not muted? Good morning. There, thank you. Thank you. All right. So anyhow, so what I'm really trying to share with you is that at this point in the game, guys, we can eat anything. Come on, guys. Have you seen the Xarelto commercial? It's like you feel like you're watching a movie, commercial for Whole Foods. It's like, there's everybody's eating salads. Arnold Palmer's eating a salad. Chris Bosch is eating a salad. Jerry West is eating a salad. What they're really saying to you in their marketing technique is that, you know what? You can eat anything. You can eat anything. So that's why we like the XA bands. You can eat anything. Do you have to draw levels? No. Here's your Xarelto starter pack. There's your DBT. Jog it off. Got it? Does that make sense to everybody? So you're good to go, right? Does that make sense to you? You're good to go. So what I really need you to understand is I need you guys to understand that when I give Xarelto and Eliquis, do I need to draw level? No. Can they eat anything? Yes. And do I need to monitor it? No. And you see, this is that other thing that keeps coming up right there. All right, let's pull back here. No, really, let's pull back and really give this some thought. Okay, guys, I want you to, we need to take one step back and take two steps forward. You ready? The one step back. Who are the two biggest filters in your system? Who are the two biggest filters in your system right now? It's your liver and it's your kidneys. These are the biggest filters you got. So they filter stuff out. So that's what your liver's doing every day. That's what your kidneys are doing every day. They're filtering things. Does everybody see this? That's what they're doing. They're filtering. All right. Stop and think about what I'm getting ready to say. And give this a lot of thought, folks. Hi, your filter's jacked up. So you've got liver disease, you've got kidney disease. You see it? Your filter's jacked up. Got it? Okay. All right. So my filter's jacked up. Let's say your kidneys are jacked up, right? Let's just say your kidneys are jacked up, right? All right. So that being said, can you get the stuff out? Let that just sink in your head for a second. So my kidneys aren't filtering well. My GFR is low. Can I get stuff out? And you're like, oh, you know what, Joe? I can't. And the same thing for your liver. Okay, now let's take the two steps forward. Now do you understand if someone's got kidney disease or liver disease, what do we do to the dosing? Do we give them more or do you give them less? And just follow common sense, guys, just common sense. You're like, well, if I give it to them and you can't filter it, then it's going to sit in the system all day. Exactly. Which means, oh, wait a second, I should give them less. And that's exactly what we do, guys. When you look at the Xarelto, the Coumadin, the aspirin, just name your anticoagulation medication of choice. They got liver disease and kidney disease. Guess what you're doing, guys? Giving them more? No, you're giving them less. And that's the key point here, guys, okay? We're going to get to Plavix in a second. We're going to get there. And then one more. Just one more. And once we get these foundations down, we're good to go. One more. Okay, so there's your filter. What was your two filters, guys? Kidneys and liver. Imagine if you can, you go to your liver, one of your filters, and you basically have it so worked up over a certain drug that it can't filter anymore. It's like, well, I'm sorry, Joe, I can't come to work today because you know what? I've got this other drug on board that I'm really having a hard time breaking down, which means that anything else you add is not going to be broken down. Welcome to the meds that you've been reading about. All these drugs, basically, remember that cytochrome 450, 452? Guys, translation, you're jacking up my filter. Got it? So now when they start talking about these, drugs that interfere with the cytochrome 450, 452, all this kind of stuff, what they're saying to you, your translation, my liver's getting jacked up. Yeah, so I'm on carbazine. Guess what? Liver's jacked. Can you filter? Not really. Phenytoin can't do it. God, does ever see those antifungals? Yeah, I got your liver all worked up, which means, okay, so let's just say I have a patient who's currently on amiodarone. And now he's going to go home with Xarelto. What's the amiodarone doing? Just orally. You're like, oh, it's jacking up my liver. So can the liver filter out the Xarelto? You're like, no, it can't. Exactly. What do you want to do, guys? Give them more? give them less. All right. So does everybody see the foundation about the kidneys and the liver? This is the point I want to get straight here, because as we dive into the other stuff, it's all going to make more sense. Okay. Does everybody see this? Okay. So this is the point I'm trying to make to you, is this. Okay. Does that make sense? All right. Very good. Let's go down the page. All right. So let's start off with antiplatelets. All right. So antiplatelet medication. So who are my antiplatelets? Well, the big one we use is aspirin. Okay. What's aspirin? Guys, I want you to view aspirin as a cheetah. It's quick. No, it's quick. He is fast. You give aspirin, when's he working? Like right now. So when would you like to throw a cheetah or something really quick at a problem? You're like, well, when the problem's going on like right now. No, exactly. I agree with you. What's going on right now? I'm having an acute MI. When do you need help? Like now. Like now's a good time. Like right now. So what do you want to throw at? What do you want to throw at it? The cheetah. This is what I want to do. I want to throw the cheetah at this. And that's exactly what we do, guys. We throw the cheetah at it. So when am I going to use aspirin? For the cheetah. And that's exactly what we do, guys. So aspirin's a cheetah. So when am I going to use? So remember the MI? What did you memorize in school, guys? Go ahead. Morphine, oxygen, nitroglycerin, and guess what the A stood for? Your cheetah. Our cheetah. All right. Put yourself on mute there, folks. I appreciate the input. So it's aspirin. Hi, I'm having an acute ischemic stroke. It's an ischemic stroke. Got it? Not a hemorrhagic, but an ischemic stroke. Come on, guys, look at your stroke protocol. For those of you doing the ER rotation, go look at your stroke protocol, guys. And trust me, you know what's sitting there? Cheetah. Aspirin. So aspirin's a cheetah. Now, he's not very strong. He's like a cheetah. I mean, he's good. He's quick. Is he strong? Well, you know, he's a cheetah, buddy. He's good for a quarter mile, but then he kind of peters out. You know, he's fast, but not that strong. So I want you to view aspirin as a cheetah. It's your quick stuff. Got it? Have an acute MI. What do you get? The cheetah. Go get him. Got it? Now, who's the stronger stuff when it comes to antiplatelet? That's Plavix. Guys, Plavix is for plumbing. Plavix, plumbing. Got it? Look at the word clopidogrel. Can everybody see the word clogged pipes in there? Can you imagine the word clogged pipes? Just imagine it. Just like, what's clopidogrel? For clogged pipes. What's Plavix? For plumbing. So when people get stents, your stents, got it? When people are getting cardiac stents, guess what they're getting, guys? Plavix. Plavix is for plumbing. So next time you see a patient, they're on Plavix, what's your next question? Well, where's your stent? Oh, I got this. How do you know I had a stent? Well, you're on the Plavix. You got new plumbing. And now I want you to pull back and think about this. So clopidogrel is stronger than aspirin. This is true. So when you look at the studies, who's stronger for antiplatelet? It's clopidogrel. But who's quicker? Aspirin. All right. Guess what you're going to see in the real world, guys? Both. So this is what the cardiologist, this is the so-called dual therapy you're reading about. What they're saying to you is this. Listen, I got a guy with a stent. So I got a guy with pretty bad coronary disease. Maybe he's a diabetic, hypertensive, high cholesterol. He's just a typical train wreck. So there's my train wreck. Got it? He's got new pipes. So what are you going to do? Well, there's the Plavix. There's the clopidogrel for the clogged pipes. And now to see what the cardiologist is doing, he's putting a cheetah with him. He's saying, hey, just in case some platelet starts acting up, I've got a cheetah to go chase him down. Now, does everybody see the dual therapy that we sometimes see in people who've got stents with coronaries? You'll see this dual therapy. I think the study, if I recall, guys, came out of Boston. This is about 5 years ago. So you'll see this very commonly out there in the real world, guys. So you'll see these two together. Okay, so on the boards, what are we given for something quick, like now? Like I need help like right now. Answer, my cheetah, aspirin. Hi, I've got clogged pipes. I got a stent. What are we getting? Clopidogrel, and that's the right answer. Then every now and then you'll see this question rear its head, right? About the ticklet. And basically, this is an old school drug. It's been around since the 60s or the 70s, guys. It's been here for a long time. And this drug here, believe it or not, is what we give when people need a cheetah, but they're allergic to aspirin. You're like, I got a cheetah cousin. Yeah, you do. And so then every now and then you'll see this question rear its ugly head. I think I saw this on Rosh, if you honest with you, about the person allergic to aspirin, comes in for, some type of chest pain. What do you want to give? And there was Ticklets sitting there. All right, does everybody see this? Okay. So now does everybody understand the difference between aspirin and clopidogrel? Got it? Then this is what you saw, guys. So when we deal with the direct oral anticoagulants, right? The DOCAs, okay? Guys, they got the word XA band in it. See it? So there's my XA bands. And so remember, it was at that, right, the 10th level A receptor site. And so it works really well. And why do we like this stuff so much? Because what is it, guys? They can eat anything. They're good to go. And we're going to get to this in a second, but I'm just keep coming back to you. So does everybody see the practicality of Xarelto and Eliquis? You give a Xarelto starter pack or Eliquis starter pack, right? You'll get on your electronic charting. I mean, you'll just say Xarelto starter pack, and off to the pharmacy it goes, and they take their 2 pills in the first day, and they just play through. What can I eat? Everything. What else is good? Good. And the only thing and guys, the reason that we basically worry about is just their kidney function. That's what we're all like, can you filter this stuff out? So there's my when we start talking about like thrombin inhibitors, remember that's just another place for a roadblock. There's dabigatran. And I always say dabigatran. So I always say, does ever see the word big? Right? Ever see the word big? Does ever see the word Prada? Can we all agree to see the word big and see the word product? Can we all agree that it's usually a big event, a big thing, when you're going to go get a Prada purse? Like, man, this is a big day because this is going to cost a lot of money, right? You're like, man, let's go get a Prada purse. Like, okay, that's going to be a few dollars here for sure, right? And so it's a big deal. So when I give dabigatran, it's a big deal. It's like you're on Pradaxa. What's the big deal about? What did you do? Right? And so what we found out that this tends to be one of the best medications that we know for non-valvular atrial fib. So this is the person who does not have mitral stenosis. You got it? So in other words, it's another possibility. So could I use, so let's just say I have a healthy 47, 48-year-old male with AFib. See him? Could I use one of the XA bands? Sure could. Xarelto, Eliquis would be fine. But since he's non-valvular, guess what else I could use as a possible treatment? I could use dabigatran. It's a big deal. Oh, that's totally a big deal. That's the point I'm trying to make. It's just a possibility. Get it? It's just another possibility. This is the one that you saw a ton of, didn't you? This is it, guys. There's your Xarelto. There's your Eliquis. This is what you saw tons and tons of. So you saw the rivaroxaban or the apixaban, right? So this is what you saw a lot of. And again, what did we like about this stuff, guys? What was it? It was quick. Here's a little piece of fact that you probably don't know. Ready? Hey, guys, how long does it take Coumadin to take effect? Yeah, good question, isn't it? And guys, the answer is 5 to 7 days to get you that INR of 2 or 3. Here's the right question. Hey, Joe, how quickly does Eliquis Xarelto get on? 2 to 3 hours. So now as everybody's saying, there you are with the DVT in your leg, and I'm going to give you a pill that you can eat anything. Got it? You can eat anything. And guess what? It works in 2 to 3 hours. Well, which one do you want? You're like, I think I like this Xarelto or Eliquis. I like these, right? And then there's these other ones that we have. But again, they have the word XA band in it. Does everybody see this? This is the point I'm trying to make to you. It takes 2 to 3 hours. There it is, guys. There it is. You can eat anything with Xarelto and Eliquis. So when I'm on Xarelto and Eliquis, I can eat anything, guys. I can eat anything. And then the big disadvantage, what's the problem, guys? Well, we don't have a real good antidote at this time. We do, guys, but right now the antidote's god-awful expensive, but it's out there, guys. It is, and I've used it before. Trust me, I've used it for people with like subdural bleeds on Eliquis or Xarelto. I've used it. Very expensive. However, that company is going to be losing their patent on it in about a year. And once that patent is lost, and now there's a generic form of the antidote, you guys are going to witness the death of Coumadin. Got it? That's what it's going to say. And speaking of Coumadin, here we are. So our vitamin K antagonist, this is old school Coumadin. So you still see this. So for the boards 2022, or if you're taking it in 2023, if you were to take the boards and you had to be academic and say, hey, Joe, what is the strongest anticoagulation medication I give? It's still Coumadin, guys. It is. Not by much. Not by much. It's an academic question. It really is. And I hate it when I see that question. I do. I roll my eyes like, you guys don't work out in the real world, right? I do those test question people. You're like, you don't work in the real world, do you? You just sit in some ivory tower and make this ridiculous question that confuse students, right? So it's a vitamin K antagonist, right? So that's our Coumadin. Remember, I got to get that therapeutic window, right? And then remember, they can't eat vitamin K rich food, your green leafy vegetables and stuff like that. So does everybody see? And guys, how long does it take them to get here? About 5 to 7 days. It's still the strongest. And then, of course, the antidote to it is vitamin K, right? So that question that you see commonly on the boards, on the review questions and stuff like that, is like, hey, what's an antidote, to Coumadin overdose? The answer is vitamin K. So now does everybody see? So Coumadin, academically, who's your strongest drug? Still Coumadin. Do you like it? No. I got to have this narrow therapeutic window. I can't eat green leafy vegetables. It takes a long time to get on board. Does everybody see the problems to Coumadin? Right? Anybody seen people on Coumadin? You ever seen them bruise? I mean, it looks like they were in a paintball conference, right? They get that black bruise that you'll see. And anybody seen like a Coumadin nosebleed knows exactly what I'm talking about, right? You'll be in the middle of the splash zone, and like all the blood's just splashing all over. It's just a hot mess. It's just a hot mess. Okay, so does everybody see? So academically, someone's got aortic stenosis, hypertension, coronary disease. He's a hot mess. Got it? He's had multiple TIAs. He had multiple strokes. What are you doing? All right, I'll pull out the strongest dog I got, Coumadin. I'll do it. I don't want to do it, but I got to do it because academically, who's my strongest guy? Coumadin. Then there's unfractionated heparin. Okay, so that's heparin. I always hate the word unfractionated. I do. It's like it's heparin, right? Okay, you ready, guys? This is a great little trick, guys. Heparin's a hose. No, it's a hose. Heparin is a hose. So when you've got a clot that's acute and it's sitting right there in front of you, so who did you throw first at it? The cheetah. Okay, so there's your MI. Comes into the ER, right? Code STEMI. So what did the paramedics do? Well, they threw the cheetah at it. Okay, that's nice. But you still got a clot sitting in his left, in his, LAD. So what do you want to do with this clot now? Oh, throw a hose at it. Heparin is a hose. So you turn the hose on and you stop the clot from getting bigger. You turn the hose off, it stops. So heparin stops immediately once you turn the hose off. It's a hose. So guys, guess what we hang in the ER in the code STEMI? Yeah, that's right. Paramedics gave him the aspirin, they gave him the cheetah. But he's going to the cath lab, right? He's got a clot in there, doesn't it? Yes, he does. What do you want to throw at it? Oh, let's throw the hose at it. Exactly. So what do we hang on the way to the cath lab? IV heparin. And then the PE. So here comes your patient, comes in, desatting in the 80s, right? Big old PE. You get the CT angiogram of the chest, big old clot. So is it time for cheetahs? Like, no, we're way past that. You got a clot. Yeah. They're hurting right now. Yeah, they are. So what can you throw at it to help it right now? You're like, oh, the hose. Oh, heparin's the hose. And now do you get it, guys? All those portacasts, Hickmans, all those, the midlines, the PICC lines, guys, after they give the infusion, what do they infuse it with? That's right. The hose. They give it a heparin push to do what? Make sure no clots are made in the hose, in their portacath or hit, or whatever it may be. So now does everybody see what heparin is? It's a hose. So someone comes in the emergency room, they have an acute PE. What do we give them? Hose. And then after they get better, they probably go home on Xarelto. Someone's got the acute MI. What do you do? Well, I gave them the cheetah earlier, but the clot's still there. So we don't throw at them. The hose. Does everybody see heparin's a hose now? That's what it is. It's a hose. You turn it on, it works. You turn it off, it stops immediately. Does everybody see this? And that's what it is. So we give it IV. So it's a hose. And then, of course, what's our treatment of choice for it? Yeah, it's our protodamine sulfate is what it is. So heparin's a hose. Does everybody see this? Then the one that everybody gets confused on. You ready? This is it. This is your Sunday Funday coming to an apex. Guys, we have little hoses. Yeah, No, you got little hoses. You got the big hose, that's heparin. But you got a little hose. Guys, that's Lovenox. So Lovenox is a little hose. Okay, stop and think hard about what I'm getting ready to say. So you're telling me, Joe, that Lovenox is a little hose. No, that's exactly what I'm saying. So I don't need the big hose, I need a little hose. Big hose, I can see it. I can see it for the clots in the coronary arteries. I can see it for the clots in the lungs. Heck, I can even see for the clots for the big DVTs that are being admitted for like a filter. Yeah, I can see that. So turn the hose on. Okay. So can I ask you a question, guys? Who carries little people? Yeah, moms. Exactly. Hey, guys, guess what we use for DVTs and PEs during pregnancy, guys? The little hose, because they got little people. Got it? Can you use heparin during pregnancy? Nope. Xarelto, Eliquis? Nope. Dabigatran? Nope. Aspirin? Nope. Clopidogrel? Nope. Hi, I got a little hose. Oh, yeah. People with little people. Oh, those are moms. Oh, so that's the treatment of choice for DVT during pregnancy. 100%. And then another thing, you saw this on your ortho rotation. Come on, the orthopedic guys, they've cued into this. Excuse me, after total knees and total hips. There they are upstairs, post-op. Got it? And they want to prevent a clot from being made right now. Is this an aspirin candidate? You're like, not really, Joe. I can't see the aspirin. So would you like to stop it now? Yeah, I would, because there's all that swelling in the knee and the hip. So can I ask you a question? Is the clot there? No, I'm just trying to prevent it. Okay, so if you want trying to prevent it, you want to stop preventing it now, then you got to pick a hose. Well, which hose would you like? The big hose or the little hose? And you're like, oh, well, he doesn't have a clot. I'm just trying to prevent it from making a clot. Let's give him the little hose. Exactly. And guess what the orthopedic people do on the individuals who are upstairs after total knee and total hip? Go ahead, look at the orders, guys. It's going to be sitting there. You know what they're going to be giving them? Daily enoxaparin or daily Lovenox, the little hose. So now does everybody see the difference between the big hose and the little hose? Does everybody see this? Or heparin's like, it's a big clot right now. I need to stop it. You got a PE, you got a clot in your coronary artery, you got a huge clot maybe in your leg that's up the iliac vessel that they want to admit for IR to go take the clot out. Yeah, start heparin. Hi, I got someone going home and she's got a little person inside. Oh, that's a pregnant mom. Yeah, what do you want to give her? Little hose. What's that? Enoxaparin, it's Lovenox. Hi, I got an ortho person. Big joint surgery. Want to prevent them from making a clot. Oh, Lovenox. And then one more. You'll see this. Go to the nursing homes. Go to the nursing homes. People are bedridden. See how they're in that state where they could they're in a hypercoagulability state because they're just laying down all day. Does everybody see that? And now, what will you see in some of your nursing homes? It's just a running order, just to prevent a clot. You're like, oh, give them some Lovenox, and that's exactly what they do. All right. So before we do the test questions, let's just do this again. One more time. I always say repetition works, right? Repetition works. Okay. So who's aspirin? Aspirin's my cheetah. When do you use them? Like right now. Like we need help. Like right now. He's a cheetah. He's quick. So that's my acute MI, acute ischemic stroke. Who is clopidogrel? Clopidogrel was who? Clogged pipes. Plavix is for plumbing. So what did you do? You gave them the stent. What are they going home with? Clopidogrel. Right? Does that make sense to you? And then does everybody see that how there's that dual therapy, how the cardiologist will put the stent in and still send him home with the cheetah? Everybody see that? And then there was Ticklet. That was our aspirin, allergy person. Okay. Then we dealt with the thrombin inhibitors. So that was my dabigatran. That was a big deal. What was one of the big deals I could actually pull this out? Non-valvular atrial fib. Makes sense. See, when I'm trying to get inside your head is more than one answer. Because one of the most common emails I get back from all my students who take my board review class, they all say the same thing. Joe, thank you for teaching me more than one answer. Because when they're on the boards, you must choose from what you're given, not what you want. And then there it is, guys, the stuff that you've been seeing Monday through Friday, right? There's our Xarelto, there's our Eliquis, all that good stuff. What do we like about it? You can eat anything. When am I worried about giving it? When the filters don't work. Which filters you talking about, Joe? Liver and kidneys. And then the vitamin K. So academically, just academically, they push me in a corner. They tell me someone's got like aortic stenosis, multiple TIAs, multiple strokes, hypertensive, high cholesterol, diabetic, just the typical train wreck. He needs the biggest dog you got. What are you going to give? You're going to give Coumadin. Got it? You're going to give it, even though you don't like to. And then, of course, we know that takes a long time to get there. So are you ready for this one, guys? Watch this. You already know the answer. You ready? Watch this. You ready? Hey, guys. So you've got someone that's going to go home on Coumadin, right? Yeah. When does it take effect? Probably about 5 to 7 days, Joe. So what are you going to do for that 5 to 7 days? What, hope? I'm like, oh, man, I didn't even think about that. Yeah, I can hope. I mean, oh, God. Well, hold on here. He might be able to make a clot in that 5 to 7 days. Exactly. So you want to stop making a clot during that 5 to 7 days? Yeah, I do, Joe. What medication could you send him home on? That's a little hose that would bridge him over. Oh, I could send him home with Lovenox. And you'll see that, guys. That's what they're talking about. Lovenox is a bridge medication, kind of bridges over until the Coumadin kicks in. And then there was heparin. Heparin was a hose, big hose. When does it work? Now, when you turn the hose on. When does it stop? When I turn the hose off. And then that was our big PEs. That was when people had the MIs and going off to the cath lab and you had the clot and the LAD. Got it? Big hose. Who was my little hose? That was my Lovenox. Lovenox was a little hose. So we gave enoxaparin to people who had little people. That's DVTs in pregnancy. That's Lovenox. Exactly. And then I could use this little hose in a lot of different situations. I could be doing an ortho rotation. Someone just got a total hip done. Could do that. Someone's in the nursing home, bedridden. I could do that. I could use this as a bridge medication if someone's on Coumadin. So until the Coumadin kicks in 5 to 7 days, I can give them a little hose. Exactly. Let's go play. Okay, so we've got to choose between aspirin and clopidogrel, right? There's the Bigatran, there's rivaroxaban, there's warfarin, there's heparin, there's enoxaparin. Got it? Okay. So here's your clinical situation. So, this is how your boards is going to look. So I got a 56-year-old male with acute chest pain. That's it. That's all you got. So he's 56 and just came in for chest pain. So what would you like to give him right now? And hopefully most of you guys going, so he's got chest pain. I need help right now. Oh, give him the cheetah. Exactly. Then I have a 27-year-old female. She's 8 weeks pregnant. Okay, we're done. I'm done with the question now. I'm just done. She's pregnant. What do you want to give her? Big hose or little hose, guys? I'm going to give her the little hose. She's got little people, right? And so our little hose would have been enoxaparin. Does everybody see this? How this makes sense? I got a 47-year-old female with a PE confirmed on CT angiogram. She's got a pulse ox of 91%, a room air. You see her? All right. So she's got a clot. And you need to take care of this clot like right now. So what do you want to give her? You're like, Joe, turn the damn hose on. Exactly. Give her heparin. I've got an 86-year-old male with TIAs. Okay, look at this guy. I mean, how much worse could you get? Elderly, TIAs, aortic stenosis. You get it? He's the worst. He's your nightmare. What do you got to throw at him? The nightmare medication, right? Coumadin. Does everybody see this, right? Okay, so that would be Coumadin. I got a 47-year-old male, had an MI requiring a stent in the LAD. So he had a stent. What's he going home with, guys? You're like, oh, Plavix. He's going home with clopidogrel. He's got new plumbing. Yeah, exactly. I've got a 33-year-old male who's got factor V. He's got a DVT, so he's just got a DVT, guys. I mean, obviously due to factor V. But you're like, okay, so he's got a DVT. How are you going to treat it? You're like, oh, give him Xarelto or Eliquis. Exactly. And then last but not least, I got a 59-year-old guy, healthy guy, and he's got atrial fib, and it's non-valvular. And you're like, if it's non-valvular, I got some choices here, don't I? I could do Xarelto, I could do Eliquis, but that's a big deal to have AFib that's non-valvular, isn't it? It's a big deal. You're like, oh, then I could do Dabigatran. I could do Pradaxa. Exactly. that's how we do this, guys. Okay, does everybody see this? Okay, so that is the way that we go about this, right? Does that make sense to everybody? So hopefully this makes more sense to you guys, because I think where it happens is a lot of times, you know, you're taught these things in school, then you get out in the real world and you're like, man, I just have no idea, you know, what's going on, you know, with all this and stuff like that, right? Does that make sense to everybody? So that's the point I'm really trying to, you know, I'm really trying to share with you here, stuff like that, right? Does that make, oh, I'm sorry, yeah, stop sharing the thing there with you guys. So this is what I need inside of you guys, is this, right? Okay, so this is what I need. What I need inside you guys is this, is that I just need you to, I need you guys to really pull back and just look at this from a perspective of, hey, you know, what drug use works best for what? But now does everybody understand who aspirin versus clopidogrel is? I got a cheetah versus a pipe medication. And now does everybody understand who the XA bands are? You're like the Xarelto, the Eliquis. They're great drugs, Joe. I can give them at any time, right? I can give them at any time, and I don't have to monitor them. And of course, the only thing I have to monitor about them is their kidney, people with the kidney function, renal function, right? Does that make sense to everybody? And then what I really need inside of you is, now does everybody understand the difference between heparin and Lovenox? Big hose, little hose. Does everybody see this? So the big hose, big problems. I've got a PE, I've got a clot. You know, if someone's being admitted for, does everybody see this? Heparin's a hose. And of course, I'm going to push that hose medication into people who have porticast, or, you know, who after their chemotherapy. After the chemotherapy is in there, why does the oncology nurse push a heparin flush? She's pushing hose medications to stop a clot. Does everybody see this, guys? And that's what I'm really trying to get inside your head, is that, okay? So if you play with those guys, come back to this video. I promise you this will make more sense to you and stuff like that. All right, guys, listen, I've used enough of your time on a Sunday, so go enjoy your day, because that's exactly what I'm going to go do, and then I got to go to work. All right, guys, so it's nice seeing everybody. Bye, guys. Bye, guys. Bye, everybody. Bye, guys.
Thank you.
Bye, guys.
Thank you.
Bye.